Welcome everybody to the VASCERN webinar on the diagnostic and management pathway for venous malformations with presenter Professor Laurence BOON. Next, please. So before we start, there'll just be a few general announcements to make. So basically, we ask everyone to please keep muted their microphone so that there's no disruptions. The webinar will be recorded so that basically we will have the recording on the YouTube channel. Any questions are to be asked in the chat box. If you really have a question that you feel you can't type out, just raise your hand and we can maybe try and get to you so you can ask your question. And if you have any technical difficulties, you can also type that in the chat box or send an email to myself and we'll try to assist you. Next, please. So just quickly to give an overview of VASCERN, we are one of the 24 European reference networks. We're the ERN on rare multi-systemic vascular diseases. And as of January 1st, 2022, we have now included 13 new healthcare provider centers. So we now gather 39 healthcare provider HCP full members, plus 6 affiliate partners. And so we are covering now 19 EU countries. We also have over 70 patient organizations who make up the European Patient Advocacy Group, and they come from all across Europe. VASCERN is made up of 6 rare disease working groups, which again, this is a new development as of this year. We have a 6th group that's just being created. So we have the HHT working group, which is hereditary hemorrhagic telangiectasia. We have the HTAD working group, which is heritable thoracic aortic diseases. They cover diseases such as Marfan syndrome and Loeys-Dietz syndrome. We have the MSA working group, medium-sized arteries, which currently covers the disease, the vascular Ehlers-Danlos syndrome. We have the PPL, which is the pediatric and primary lymphedema working group. So they cover a variety of diseases, all involving lymphedema. We have today's working group, which is the vascular anomalies working group, who also covers a large variety of diseases, more than 40 rare diseases, all to do with vascular anomalies. And we have currently created a 6th working group, which is the neurovasc working group. And at present, they will be covering CADASIL and Moyamoya disease. So these are the 6 working groups that we currently have. All of them have involvement from the European Patient Advocacy Group in the form of a patient advocate, co-chair and deputy co-chair who participates in each of the meetings. So for all information on VASCERN, including our work packages and various projects, you can go to our website, vascern.eu. Next, please. So the VASCA working group. Today, our presenter is Professor Laurence BOON, along with Professor Mika Vikula and Professor Leo Schutzkuhl. She co-chairs the VASCA working group. So Professor BOON is a plastic and reconstructive surgeon from the Center of Vascular Anomalies at Cliniques Universitaires Saint-Luc in Brussels, Belgium. So without further ado, I'll pass this on to you, Professor BOON. Thank you.
Thank you, Natasha, for this kind introduction. It's a real pleasure for me to be here with you and in order to discuss the pathway on venous malformation. And before starting, I would like to acknowledge also Professor Anne Daumartin, who's a dermatologist in Caen and who has initiated this pathway on the diagnostic and management of venous malformation. So here are my disclosure. And as Natasha said, vascular anomalies comprise of several types of vascular lesions and disorders. About 40 different vascular anomalies are encountered, and it's very difficult if you don't have a precise diagnosis to manage correctly these patients. So in order to have that, you need a common language that need to be simple, but not simplistic. And for that, we have adopted the classification of the International Society for the Study of Vascular Anomaly, the ISSVA, that you can see on the website isva.org, where there's division of vascular anomalies into vascular tumor and vascular malformation. The beauty of this classification is that it will be modified with the increase of our knowledge every 2 to 4 years whenever necessary. Today, we're going to discuss about venous malformation. And if you click on venous malformation on the ISBA.org classification, you will see all these different venous anomalies, and we'll discuss this further later. But to start, you need to know what do you mean by venous malformation. So these are abnormal and increased in number and not effective venous dilated veins, like here, who has an abnormal and a quite sparse smooth muscle cell layer. You see here with alpha smooth muscle cell actin marker that there is smooth muscle cell in some part of these veins, but not in all of them. And this is why they have the symptoms that we'll discuss later on. In some venous anomaly, glomovenous malformation, you again have this atactic venous-like channel, but they are surrounded by glomus cell, which are undifferentiated smooth muscle cell layer. And this will also explain why they are less compressible on palpation and painful on palpation. Then you have also mafuchi syndrome, which again has a dilated venous-like channel with spindle cell hemangioma surrounding, and VVM has cluster of venous-like channel. So clinically, when do you suspect a venous malformation? Of course, simply, it's veins. So whenever the skin is blue, you have to think of a possible venous malformation. Like here on this small girl on the forehead, the foot, or then in the mucosa or the tongue here. It's pathognomonic of a venous malformation when the lesion is compressible by palpation or fills up on depending position. Like here, it's the same hand of the patient, which is emptied because the hand is put upwards, or filled with blood when the hand is put downwards. This is really typical of venous malformation. Sometimes the other specific is that these malformations are painful at awakening, especially when they are located on the extremity, because the patient is not moving his hand during or leg during night, and it's filled with blood, and it takes some time for the patient then to recover the function of the extremity. It's also painful after exercise, and sometimes they can experience pain for 1 to 2 weeks due to a local thrombosis. Some other venous malformation, like glomovenous malformation, or when you have the formation of a thrombus, it will be firm and pain on palpation, and then you will have phlebolith also that you can feel on palpation. You can see them very nicely when you operate, or on plain X-ray. Again, this is pathognomonic of a venous malformation. It's a low flow malformation, so there is no thrill and it's not warm on palpation. In rare instance, you can have multiple lesions, or you can have other vascular malformation associated with venous malformation, or other vascular or non-vascular anomalies like limb hypo or hypertrophy that will then be involved in syndromes. And in very rare instance, you can have also family history. So after suspecting a venous malformation, what do you need to do? Well, first of all, you can confirm the diagnosis with very simple Doppler ultrasound. But you need to have an experienced radiologist that talk the same language as you, so know the ISBA classification. If there is enough detail on the explanation of what the radiologist will see on the Doppler ultrasound, it will say that there is just fluid dilated channels, liquid channels, venous, that are compressible when it's compressing with these probes. This is again pathognomonic of venous malformation, in contrast to lymphatic malformation, where it's the same cysts, but which are not compressible on palpation. And again, it's a low flow malformation. When you want to deal with a venous malformation and manage it and know what treatment you should propose to your patient, you need to do an MRI. Why? Because this will give you the exact location of your malformation. Sometimes it's what you see in the clinic that you will see on the MRI, but sometimes it's just the tip of the iceberg that you will see clinically, like this patient who seemed to have the venous malformation on the heel, but actually it involved the heel, the entire foot, and the ankle. Sometimes also the patient will say that he's asymptomatic, like this patient who's has seemed to have a small venous malformation on the tongue, but when you look at the MRI, she has also airway compression, and she has never realized that because she's living every day for her entire life with a venous malformation. And actually she was sclerosed, and after that she realized that how fatigued she had and how tired she was for her entire life. So you need to ask the right question to your patient. In very rare instance, if you're not sure that and don't have typical Doppler ultrasound or typical MRI, and you're not 100% sure of your diagnosis, don't hesitate and do a biopsy in order to have the histological diagnosis, either a needle biopsy or an open biopsy. So you have your diagnosis, and you can have either, which is the most common, the sporadic unifocal, that can be small but also quite extensive. You can have sporadic multifocal, meaning that the patient has multiple lesions, like here, same patient. They're usually smaller than in the sporadic unifocal, and there's no family history. You can have also familial multifocal. So the patient again has multiple focal lesion, often small. And when it's familial, often you have also mucosal involvement. And of course, venous malformation can be part of a syndrome, like here, where you can have all combined malformation. You can have here, you have a capillary lymphatico-venous malformation or capillary venous malformation. This is a Clove syndrome with other associated anomalies. So let's start with the most common, the sporadic unifocal venous malformation. It can be anywhere on the body. It can involve the skin, like here. It can be quite small. It can involve joints, like here. Airway, like this patient who has difficulties in eating, in speaking, and airway problem also. And it's a patient from Anne-Martin, and he died of airway compression. It can involve also and completely dilate the nerve, like you see here. This is the radial nerve. It can involve the GI tract. It can involve the muscle, or just involve the muscle, like this patient who has normal skin but functional disability because of the muscle impairment. She also had perineal involvement and daily bleeding. So whenever you have genitalial or perineal location, you need to do an MRI of the pelvis, because several visceral organs can be involved with your venous malformation. This patient wanted to be treated. We did an MRI, and this really highlights you the importance of the venous malformation that is not only on the lip, but also on the entire half of the face. Let's go for the less common, the sporadic multifocal. So this patient has multiple lesions. They can be cutaneous or subcutaneous, as you see here. They're usually very well localized, like on the, when you operate these, you can easily resect them. But they are multiple, and you see on the MRI, they can also be in the muscle. It's more difficult to find them. They're also caused by somatic tech mutation. These patients often have also coagulation abnormality. Because I forgot to tell you that 50% of sporadic venous malformation are associated with coagulation abnormality. They can have very high D-dimer and even low fibrinogen. And so you need to identify this coagulation status before managing your patient, because otherwise it can decompensate and cause severe bleeding, per or post-operative, or even after sclerotherapy. Another disorder with venous anomaly is patient who has a large VM lesion at birth. These two, as you see on the MRI, it's quite extensive. You see that this patient had another small VM here and has on the MRI another one on the contralateral side here. They often have either at birth or later, around 6 years of age, the appearance of this multiple bleb, rubbery-like occurrence, often on the palm or the hand. And this is typical of what we call blue rubber bleb nevus syndrome. They are at high risk of GI lesion. They can be in the stomach or the intestine, and they can cause chronic anemia, severe, that necessitate transfusion. They can cause also intussusception and chronic abdominal pain. So you really need to identify these lesions, and whenever you have these hyperkeratotic lesion on the palm and the sole, even if the patient is asymptomatic, has normal hemoglobin, you should do a capsule, a GI capsule, in order to identify these lesions. And they often have low molecular weight coagulation abnormalities with very high D-dimer. They are also caused by somatic type 2 mutation. More rare is patient who has these lesions. They are multiple nodules that are hard and associated, as you see here, and they are associated also with multiple enchondroma that you see here, that you can resect with a curette. And this is mafuchi syndrome. You see on the plane X-ray these enchondroma, and then the phlebolith that is characterized of these venous anomalies. They can be quite dramatic, as you see here. This is a hand of a patient with mafuchi. They have no coagulation abnormalities, and they are caused by somatic mutation in IDH1 and 2. So when you have these lesions, you always have to do an X-ray of the hand and the feet. Other bone can be involved, but it's mainly hand and feet. And then the last sporadic multifocal venous anomaly is varicose venous malformation that can be quite extensive, much more localized. They are hyperkeratotic, like you see here. They are papules. They can enlarge with time, and they are mainly on the extremity. These lesions usually involve just the skin and the subcutaneous tissue. They don't involve the muscle, or very rarely, or the tendon or the ligament or the joints. And they are caused by somatic MAP3K3 mutation. Let's now continue with the familial venous anomaly. These are about 1% of venous malformation. They are small, but like for all familial lesions, they are multiple. So whenever you have multiple lesions, think of a familial occurrence. They are autosomal dominant. They can be quite extensive. And they are all caused by germline mutation of TEC. What is characteristic of this VMCM, venous malformation cutaneomucosal, like the name said, you often have a mucosal lesion. There is variability within the family and within several families, but they all have multiple mucosal and cutaneous lesions, sometimes intramuscular, but it's mainly cutaneous and mucosal. And another familial, which is also multifocal, which it's not compressible on palpation. And in contrast to VM, it is very painful on palpation. And this is typical of glomovenous malformation. This patient, for example, could not wear jeans because the tissue was too hard for her, and she experienced a lot of pain due to jeans. They do not have coagulation abnormalities. This is also specific of glomovenous malformation. They are inherited as an autosomal dominant pattern. They are until now all caused by germline mutation in glomerulin. And in rare instance, they can have plaque-like lesion like this, which is more like, look like capillary venous, but it's a glomovenous malformation. So if you do a blood test of this patient and test for glomerulin, you will have the exact diagnosis, glomovenous malformation, and not capillary venous malformation. Again, as I said, this is a GVM, so it just involves the skin and the subcutaneous tissue, and you see that the joint is very well preserved by the malformation. So when you operate, it's much more easy to go around the malformation because it's well located. It's more like a grape than a venous malformation. And this is again typical of glomovenous malformation of the scrotum. Although it's quite extensive, when you see on the skin, you see that the testicle is well preserved by the malformation because it's a GVM and not a VM. The third familial venous anomaly, it's hccbm or hyperkeratotic cutaneous capillary venous malformation that you can see here. It can look clinically a little like a VVM, and it's not always easy to make the difference in the clinic. So whenever you have these lesions, in about 8% of these patients, they will have inherited cavernoma in the brain. So when you have this lesion, you should do a brain MRI in order to exclude cavernoma that will be then inherited as an autosomal dominant pattern. These are called by germline mutation in CRIT or CCN1 locus for cerebral cavernoma. And again, you see on the histology, you have this ectatic venous channel or capillary venous channel. And then to finish, you have the combined or syndromic, where venous malformation can be associated with other vascular malformation like capillary lymphatic malformation in Klippel-Trenaunay syndrome and overgrowth of the extremity. You can have here a Clove syndrome with, in this instance, capillary malformation associated and lipoma and scoliosis, or here also a Clove syndrome. And these are caused by somatic mutation depending on the type of combined or syndromic malformation. But they're all part of the overgrowth pathway, so I will not discuss these combined malformation today. So when you have the diagnosis, this very specific, precise diagnosis, then you can think of treating your patient. And for all of these various types of venous malformation, you have some common management approach. As every patient is unique, you should discuss each, except a very localized venous malformation, but all the other one, you should discuss it in a multidisciplinary, or I would rather say interdisciplinary approach. This does not mean that you send the patient to the orthopedist or you send the patient to the vascular surgeon. It means that you have to discuss the record of the patient all together, being, as you see here, in a single room where you discuss the patient, what would be the best treatment and in which order. Should we start with medication, with sclerotherapy, or with surgery? Should we combine some treatment? So this needs to be an interdisciplinary approach, and that's very important to be able to manage the patient the best way for each patient. Of course, let's start with the more simple one, is conservative treatment, and elastic compression is very useful, especially for VM on the extremity. You have to discuss with the bandage company in order to know what they can do, if they can propose some very nice, effective, but easy to use garment for children that can be customized with different colors so that the patient will accept it. Sometimes also when there is some specific pain in specific location, we can also add with the compression garment some silicone to increase the compression in some area without damaging the patient and without increasing the pain. You can have some easy way to fill in these garments and to make everything more easily so that the child will accept his elastic compression and will consider his elastic compression as a friend. And this is very important for children. You will have also, for some superficial lesion, very well localized, you can use the ND-YAC laser. We will discuss further the consumptive coagulopathy that is very important to manage. And the best painkiller is usually non-steroidal anti-inflammatory drug. And the low molecular weight heparin, you have to think of it when you have increased the edema and the patient experience acute pain with increase of swelling and firmity of the lesion. It caused by a thrombus within the venous malformation, and the best way to reduce the pain is to give a 10 days low molecular weight heparin as a prophylactic dose. Invasive treatment, you will have then, when it's well localized, then you can operate the patient immediately. Here, it's not very common, but you see that when you operate them and you don't go into the malformation, it doesn't bleed, and you nicely remove the malformation. Don't forget that usually the draining vein is in the deep part of your malformation, and you need to ligate this to avoid hematoma postoperatively. Another very important management for venous malformation is sclerotherapy. This needs to be done by experienced interventional radiologists, and you see he puncture directly through the skin the venous malformation, do a phlebography to be sure that there is no draining vein where the sclerosing agent could go, and then inject the sclerosing agent. This is a patient with a VM of the lip that distort the lip, as you see here. You see the extension on the MRI. And the question was, do we operate because there's deformation of the lip, or do we sclerose, or do we do both? Actually, if you operate in this instance, you will have then bleeding, important bleeding perioperatively. you will not see the structure, and there will be immediate recurrence. So the best way is first to ask your interventional radiologist to dry the lesion as much as possible. Here you see after 2 sclerotherapy, the lesion is completely dry. There's still distortion of the lip, but this is more like a normal non-vascular malformation lip distortion. So you will then operate and have a long-term result because it has first been sclerosed before you operate. So you need to discuss easily with your interventional radiologist before thinking of operating this patient. You can also have, for a patient who has persistence of the lateral vein, like the vein of Cerelinus in Klippel-Trenaunay syndrome, you will ask then your vascular surgeon or the interventional radiologist to block this vein, because this can cause pulmonary embolism, and it can be done either by sclerotherapy or radiofrequency. And you see here, when you do the radiofrequency, you see the destruction of the vein in contrast to the area that was not treated with radiofrequency. Cryoablation is another possibility that can be used for some deep venous malformation. And of course, with our knowledge, now we have diagnostic medication with Cerelinus. And these are 2 patients that has been, this patient has a large venous malformation of the tongue. This one has a capillary venous malformation of the lower extremity. She's 2 months of age and has daily bleeding. She needed twice daily low molecular weight heparin injection because of the bleeding. And this is what we could achieve thanks to Cerelinus medication. Why did we use Cerelinus? Because with our knowledge, we know that venous malformation are caused by activation of Tie2 or PIK3CA, mutation in Tie2 or PIK3CA that cause hyperactivation of Tie2, PIK3CA, AKT, and mTOR. And we now know that rapamycin, so Cerelinus, is a specific inhibitor of mTOR, and that's why we test it. And now we know also that alpelisib is a specific inhibitor of PIK3CA. So this was a huge revolution in 2015 when we showed that for the first time we could treat a malformation, and more specifically venous malformation, with a medication. And we then did a phase 2 trial on 18 patients, and we are now in a phase 3 trial, European trial, where we want to know, involve 250 patients in order to know which is the best indication, what we can achieve with this medication, and what happened also when we stop the medication. Do the patient recur? Would that help to propose a sclerotherapy or surgery that was not possible before, and what would be the long-term side effect? So what we learned is that we can definitely rapidly control the symptoms of the venous malformation. This is the patient I showed you before with a very extensive venous malformation of the lower extremity and around the anal and the rectum. She had continuous pain and daily rectal bleeding. And as you see, when we start Cerelinus, the bleeding quite quickly stopped. Her pain reduced tremendously, functional impairment reduced also. So she was very stable. Then she decided to stop Cerelinus by herself because of headache, and her symptoms recurred. She started bleeding again. She continued, she restarted Cerelinus by herself, and again, the symptoms went away. So this is really the proof of concept for rare disease that a medication is working. We learned also that we can improve functional limitation. This patient has a VM of the vocal cord, and although on the MRI there's not really a change, the patient was able to speak not only 10 minutes before feeling fatigue, but 1 to 2 hours without any problems, thanks to Cerelinus. And this patient had a VM around the spine, causing paresthesia of the upper extremity. And after 1 year of Cerelinus, you see that the spine is not compressed anymore and the patient was symptom-free. Another more specific management for patients with Bleuler-Blatt-Neves syndrome that we discussed earlier. Of course, this can cause chronic anemia, quite severe. So you need to give iron supplementation and blood transfusion sometimes. Patient with multifocal glomerulus malformation, especially for the plaque-like lesion, you can do laser and you see improvement of the skin, the aspect of the skin. Patient with varicose venous malformation, VVM, as I said, they're often cutaneous and subcutaneous. So we would prefer surgical resection instead of laser that can cause often ulceration. Same thing for VVM. And when you have a V or hyperkeratotic capillary venous malformation, think of neurological monitoring, because this can be just the stigma of multiple cerebral carcinoma. And also for mafuchi, you would prefer surgical resection, and you need to look for cancer monitoring because these patients are at high risk of developing a cancer within their life. I told you that about 50% of patients with venous malformation have associated chronic consumptive coagulopathy with high D-dimer and sometimes low fibrinogen. So you have to measure the D-dimer and the fibrinogen for each of your venous malformation. You're sometimes surprised that what you consider a small VM has actually a very high D-dimer, especially when they are multiple, they all have coagulation abnormalities. If the fibrinogen are normal, you have to consider low molecular weight heparin in case of pain due to local thrombosis. Before surgery or sclerotherapy, and when you will start the low molecular weight heparin will depend on the amount of your D-dimer level. Sometimes it's 1 week before or 1 month before, sometimes it's just the day before the surgery, and you continue for about 5 to 15 days. During pregnancy, patients with venous malformation can experience pain, and this pain can nicely be reduced with low molecular weight heparin, which is not harmful for the fetus. And whenever there is, of course, a risk of thromboembolism, especially in patients with CLOVE or KTS, you have to put this patient on a long-term low molecular weight heparin. With oral contraception, usually we would prefer progesterone-only pills. Some patients will support estrogenic pills. Some of them will experience pain during the first month, and then after the second or third month, there will be reduction of pain. So it really depends from one patient to another one, but in general, we would prefer progestative-only pill. And if there is low fibrinogen associated, you have to send your patient to a hematologist in order to have the best low molecular weight heparin treatment with the best medication, and often then you will use oral low molecular weight heparin that will be more suitable and easy to use for your patient. So in conclusion, I would say that venous malformation, it's a challenging management. Every patient is different. So that's why, first of all, like for every malformation or every disease, you need to have the precise diagnosis, and in order to have a precise diagnosis, you need a common language, which is the language of the classification of the ISVA. you need to have a multidisciplinary team because, as I said, every patient is different. And you cannot say for every patient, as I'm a surgeon, I will operate them all. No, it's not because they come to me as a surgeon that I will operate a VM. Often I will first ask and see if the interventional radiologist cannot drive the malformation as much as possible. Or sometimes I will wonder if it's very well, if the VM is well localized and that I know that I can surgically resect, I will resect. If it's not so well localized, but still possibly managed with interventional radiologists, often it will be sclerotherapy. If the patient has a very extensive, for example, the entire leg involved, even sclerotherapy will be like a small droplet within the ocean. So we will then start first with Cerelinus and then see if we can then later on add sclerotherapy or surgery. So definitely you need to have a single patient management for every patient with venous malformation. You need to have complementary exam. The correct one are Doppler ultrasound, MRI, and the coagulation status before management. There's no need to do an arteriography. This is anomalies of the vein, so the arteries are normal. As I said, sclerotherapy, surgery, or diagnostic medication, and the future is really bright with the increase of our knowledge. There will be more and more medication that we will be able to test for our patient with venous malformation. And I'm sure that now we use Cerelinus. There is later on now there is also alpelisib. We need to know when to use Cerelinus, when it's best to use alpelisib, and this is still on clinical trial, but our knowledge will increase. That's why we need further translational research. Is really essential in order to increase the knowledge of the physician that are dedicated to vascular malformation and to better and better treat our patient and hopefully even cure a patient with a very extensive venous malformation, which is something that we cannot do for the moment. And please do not treat your patient just to do something because you feel bad that you will say to your patient, I'm sorry, I cannot do anything for the moment. Well, just be humble and tell the patient, because it's best not to harm your patient. And if you explain that there are research working on what they have and that hopefully one day we will find something better, they will be very happy. And I would like to finish by thanking the VASCERN and the VASCA working group, because it has been really fun to work all together and to collaborate. This is the only way. Don't forget that these are rare disease, and working all together is the only way to improve our knowledge in order to take care even better to our patient. And I would like also to highlight the importance of patient organization, because as I always tell to the patient, we know their disease, but we do not live with them. And the patient can really help us in giving us what's the most difficult for them. And often they have find some small tricks in order to help them in everyday life. And this is something we as physicians need to learn from them, and they will learn from us what they have and how they can also improve them everyday life. And has been really, really very great to have this VASCERN, and we now have 6 more countries and center that are part of VASCERN, and I'm really eager to work with them. And I thank you for your attention. And
thank you.
Answer questions.
Thank you, Professor Boon. That was an excellent presentation. You really illustrated the pathway very well, and I think it's been very beneficial to everybody connected. So if anyone has any questions, as Professor Boone mentioned, you can type them in the chat box. If you feel you have a question that's too long to type, you can raise your hand. So we'll wait a little bit to see if there's any questions. We have a few comments from Dr. Bazalga saying, excellent presentation.
Thank you, Anna.
While we're waiting to see if there's any questions, I'll just mention that the recording of this webinar will be available on the YouTube channel, and you can follow our Facebook, Twitter, YouTube, and LinkedIn accounts if you'd like to know when that'll be available. So we have a question concerning consumpting coagulopathy. Do you consider direct oral anticoagulation?
So yes, we have oral anticoagulant. Pradaxa is working very well. And we really ask then the hematologist who's decided whenever there is, especially for adults, because this is not really done yet for children, but for adults, whenever there is very high D-dimer and of course when there is low fibrinogen, we always send the patient to the hematologist, and then he see if he can get the reimbursement for the oral low molecular weight heparin. And of course, if it's possible, what we realize also is that in contrast to fraxiparin or Clexan, the products are often, or in some patients, it really reduces even more the D-dimer level.
Great, thank you. There's another question. How can you differentiate clinically a varicose venous malformation and a hyperkeratotic capillary venous malformation? It would be important to know who to perform a CNS scan.
I completely agree with you, Lali. Thank you for the question. Well, I cannot. I must admit that I have no idea how to differentiate. I'm still working on that. And so whenever I have this VVM or hccbm, I ask if there is any family history that will give us some idea. And if they say, but even if they say no, I look for any neurological symptoms and often explain to the patient it would be good to do a brain MRI to exclude it. And often they're happy to do it. There is the question, of course, when it's a child, because we need general anesthesia, so it's a discussion with the parents. Depending how, if the patient is asymptomatic, if the parents are scared, we would do the MRI. If they don't want general anesthesia for their child, we will then just look carefully for any neurological symptoms and wait.
Thank you. Should we use Cerelinus or other drugs before, during, or after interventions?
So what we have quite a lot of experience with Cerelinus now, because we have about 200 patients in our multicentric European study, and we've done before that also. We have starting to realize that in contrast to what we do for transplant, kidney transplant, where they stop the Cerelinus before surgery because they're afraid of healing, here actually is the contrary. When we know we will have, especially when there is in combined malformation and when there is lymphatic involvement, and we know there will be partial resection, we then first start with Cerelinus and continue the Cerelinus during and especially after surgery, because this will reduce the complication. It reduces the oozing, the swelling, and it will increase the efficacy of the healing because of Cerelinus. And I think it's just because in our vascular malformation, the Cerelinus is more normalizing the abnormality of the status due to the mutation, in contrast to the kidney transplant, when you hyperactivate hypoactivate the signaling pathway. So now here in our patient with venous malformation, we normalize this pathway by using Cerelinus. So I never stopped, and I oblige, if it's another surgeon who operates in our institution, I oblige him to keep Cerelinus during surgery.
Thank you. How do you treat intramuscular VMs when they involve 1, 2, or 3 muscles or parts of them?
That's a difficult question. For the moment, we put them on Cerelinus. If they sometimes they do respond to Cerelinus. If they don't, then we see we try to identify the most painful location and sometimes do partial resection also.
Great, thank you. I had knowledge that Cerelinus worked better on lymphatic malformations. Is it really efficient in pure venous malformations?
Oh yes. Yeah. This is. I don't think in our study we have more venous malformation than lymphatic, because we are well known for VM, as we identify the cause of VM, and we have 85% improvement of venous malformation, which means improvement in symptoms. In lymphatic malformation, what you see most is reduction of volume on the MRI, but we don't treat an image, we treat a patient. And if the patient has less pain, improved functional limitation, it's a response to Cerelinus. And that's what we see with venous malformation. 85% of our patients has clinical improvement and this increase of quality of life.
Okay, great. Another question. In case of side effects with Cerelinus, do you have experience with Everolimus as an mTOR inhibitor?
No, I don't. Usually the side effects of Cerelinus are minor. We even tell the patient if the most common is canker sore, and we tell them that they can stop for a couple of days if they want, and then restart the medication when their canker sore is off. And I have some patients even who are not in the trial, but knows their malformation very well. They know the medication, and so they know, for example, often in the winter they have more pain, so they take the Cerelinus just during winter, and then they stop during summer. And it's really a drug that the patient can monitor when he has been on the medication for a while, with physician looking very carefully at the symptoms and side effects.
Okay, thank you. Few more questions. If there are brain VMs without complications, how would you cope with that situation? Treatment or not?
I think this is a patient-to-patient discussion. It really depends. If with the neurosurgeon and the neurologist, if there is some, it really depends. I think if there's no complication, I would rather not treat, because the treatment can cause complication. But I think that you need to discuss with your neurologist and neurosurgeon and the team.
Okay, so another question from a doctor. We miss a good treatment option for large VMs of the tongue. Despite sclerotherapy or diode laser or supradecal injection, we experience rather quick relapse. Also, the treatments are giving significant post-operative morbidity. What would you recommend?
Well, I would recommend to first start for the tongue with Cerelinus, as you saw the picture. Now, I had during the trial another patient with a VM of the tongue, exactly the same thing, but she had previous cryotherapy and surgery, and she actually did not give that great response to Cerelinus, probably due to fibrosis. So for this location, I would rather start with Cerelinus and see the effect. Another sclerosing agent that seemed to work maybe better for the tongue is maybe bleomycin. At least I have seen some very good results with bleomycin in our institution. But it really, some patient will respond, some patient will not. So there will always be a patient that will not respond and a patient that will respond. It's a patient
case by case. Yeah. Okay, we have one more question. Do you consider foam sclerotherapy if the VM is infiltrating joints or bone?
We would prefer doing surgical resection. Whenever there is involvement of the joint, we as soon, even without any symptoms, we would rather operate, because every intra-articular bleeding will cause potential cartilage destruction. And if the cartilage is destroyed, even if you remove the malformation and in a sense cure your patient regarding the VM, it will still have pain due to the destruction of the cartilage that will not come back. So we had a small series of 8 patients with joint venous malformation, and we really experienced that the one that were operated before any destruction of the cartilage went very well afterwards. Now, what we have seen also in very extensive venous malformation of the lower extremity with joint involvement, we know that there will be local recurrence within the joint. So our orthopedists prefer to do the resection of the VM by arthroscopy than by open surgery. That is much less painful and heavy for the patient, and anyhow they know they will at some point need to go back, and that will be done under Cerelinus treatment.
Thank you. That looks like for now the last question. I don't know if there's any final ones, but we are approaching almost exactly the hour, 6 o'clock. So that looks like we've had a really good discussion, and thank you so much, Professor Boon, for all your expertise on this topic. I think it was very, very valuable to everybody. There's no other questions.
Thank you everybody for being part of us and of today. It was real fun to discuss and being able to answer all these questions, and I really hope that we can help even better our patient with this disorder. It's really what we want, and that's the beauty of this VASCERN, because we really feel that we are doing things and really improving and also diffusing our knowledge to a wider population.
Yes, and the pathway that was discussed today can be found, of course, on the VASCERN website. The next webinar will also be coming up on the 1st of February. It'll be the final pathway from the VASCA working group on capillary malformations. So please stay tuned to register for that one. And we thank you all for joining this evening. Thank you again. Have a good night.
Thank you. Bye-bye.
Bye-bye.